Hi, my name is Yana Pogosian, and this is the presentation for the Week 6 SOAP note. I will be presenting Mr. CD. This case was very interesting to me because we actually got to go to the hospital to do rounds with my preceptor, and I haven't been in a hospital for a very long time, so it was very refreshing for me. Now, Mr. CD is a 78-year-old white male. His date of birth is March 21st. He has Medi and he's married. This is a 78-year-old man that we saw in Sherman Oaks Hospital for routine rounds and follow-up. His chief complaint was pain while he was initially admitted to the hospital. So Mr. CD is a 78-year-old man known to our clinic for over a year. He was newly diagnosed with metastatic prostate cancer with the T-spine cord compression status post decompression, which was back in August. Previously, he was in fairly good health. Last night, he presented to emergency room with complaints of severe back pain that he rated 10 out of 10. In AD, they did UA, and it showed 1+ bacteria, 1+ ketones, and 500 leukocytes. Esterase, white blood cell count was 68, CRP 69, which was strongly suggestive of cystitis. He was started on Zosyn IV every 6 hours in emergency room and admitted for further workup. Today he was seen by us in the hospital room on 3 North for follow-up and discussion of the plan of care in the hospital and discharge planning. So for his constitutional, for ROS, he denies fevers, chills, reports that he had severe low back pain, 10 out of 10 yesterday. Today reports pain being tolerable at 3 out of 10. He denies pretty much all of the other systems in terms of his eyes, his ears, cardiovascular. There is no symptoms at all. He just complains of today's pain at 3 out of 10. Now, his past medical history is CAD, COPD, depression, DJD, prostate cancer, and retinal vein occlusion. He did receive he had his ophthalmic and dental exams not too long ago, and he's up to date with the flu shots and pneumonia vaccines. Past surgical history is spinal decompression. He also had angiogram done. He had a right hip replacement and tonsillectomy. He's not allergic to any medicines or environmental factors, but he's allergic to gluten. You can see on my note, there's his medications from home and the ones he's currently taking in a hospital. So for his family history, mother died at 62 from heart attack. She had some kind of a heart disease. He wasn't able to really tell. Father had BPH. He died at 72 for unknown cause. He's not sexually active. He is married. He used to smoke for 40 years, quit 20 years ago. A very rare drinker of alcohol, maybe 1 glass of wine, and denies illicit drug use. He is at home on a regular diet, non-ambulatory. Previously, he was a firefighter, now retired, lives in private residence with his wife who cares for him, and depends on most of his ADLs, 5 out of 6. He is currently full code. So for laboratory results, when we saw him, which was last Friday, his white blood cells was 6.05, hemoglobin, hematocrit 10 and 27.9, platelets 264, sodium 136, potassium 4.4, BRM creatinine 23 and 1.70. His CT scan of the pelvis without IV contrast showed cystitis, abnormal wall thickening with enlarged adjacent perirectal lymph nodes or masses, moderate bilateral pleural effusions with adjacent atelectasis, calcific pleural plaquing with in both lung bases, coronary artery calcification, and postoperative changes of the spine and the right femur. On the exam, he was alert, cooperative, and in no distress, appears well-groomed. His HEENT was normal, respirations was normal, clear to auscultation, no wheezing. He is, however, on 2 liters of nasal cannula, continuous, and setting at 94%. He also has a Foley cath in place, draining yellow urine. His pulses are 2+, symmetric in all extremities, no skin color changes or wounds. He has bilateral lower extremities are flaccid, and some sensation he reported at hips. He's appropriate mood and effect. So for our differential diagnosis, we had acute UTI, acute prostatic cancer with mets to spinal cord, acute back pain, and severe protein malnutrition. For the UTI, we discontinued his Zosyn that was started on in the ED and started him on cefazolin, 1,000 milligrams IV piggyback every 8 hours. And we're going to continue to monitor. For acute prostatic cancer, we wanted the follow-up with oncologist, Dr. Posadas. He needed... We feel that he needs systemic therapy. We started him on Dega Relics with loading dose today at 240 milligrams sub-Q times 1 now. Then we also started him on Methane with 120 milligrams sub-Q every 4 weeks. This patient does require staging of the disease, so CT scan with CAP with PO or IV contrast was ordered, but currently pending renal function test results, so we can determine what kind of contrast we can use on him. We also ordered TC99 bone scan to check and see if the cancer has metastasized to the bones. We recommended to return to clinic after discharge from the hospital within 4 weeks for follow-up. For his acute back pain, we continued his present pain control, which is in medication list up above in this note. And we ordered pain management consult today because of the cancer pain is so severe that required hospitalization. For his severe protein malnutrition, pre-albumin pending, and nutrition consult was ordered. He is currently on regular diet as tolerated. His DVT prophylaxis, he's on heparin sub-Q twice a day. We discussed with patient and family possible hospice and palliative care. Palliative team consult was ordered. Discharge planning for Monday if patient continues to be stable. Discussed plan of care with patient and family. Social work evaluation for community resources, DME delivery coordination, and home agency identification, whether it's home health or hospice, whichever one family will decide. We did discuss all of the options and they will let us know. Then also we educated patient about disease progression and prognosis, provided emotional support, and answered all the questions that patient and family might have. We did put him on fall precautions and aspiration precautions just in case, and continued all current medications and current plan of care. This case was discussed with Dr. Karungian and my NP Manda Kelly. This case was super interesting to me, and I look forward to seeing this patient in the clinic and finding out what happened next. Thank you.